Welcome back, Focus learners. In our last explainer for Decode Healthcare with Harshal, we navigated the turbulent waters of pulmonary emergencies. Well, today, we're stepping right back into the high-stakes environment of the emergency room for part 4 of our series. We're looking at conditions where literally every single second counts: acute electrical cardiac failures and major arterial disasters. You know, the human heart and its major plumbing are absolutely phenomenal, but when they fail fast. Let's get right into it.
So, picture this. You're staring at a patient monitor in the ER. What exactly separates a rhythm you can shock back to life from a fatal flatline? And on the structural side of things, why is mistaking a tearing aortic dissection for a ruptured aneurysm something that can prove immediately fatal? Well, these aren't just clinical trivia questions, right? They're the fundamental differences that drive immediate, life-saving treatment protocols, and ultimately how these critical encounters are translated into medical documentation.
Here's our roadmap for today's explainer. 1. Decoding high-stakes cardiac emergencies. 2. Shockable lethal cardiac rhythms. 3. The flatline. True asystole. 4. Aortic dissection disasters. 5. Ruptured aortic aneurysms explained. And 6. IC decoding for cardiac crises.
Section 1. Decoding high-stakes cardiac emergencies, system failure, and red flags. Okay, before we get into the specific rhythms, we really need to understand what acute system failure actually looks like. These are illnesses or injuries with an immediate risk of death or severe disability that require urgent right-now intervention. A huge hallmark of a life-threatening acute condition: unstable vital signs. If you see severe hypotension with a systolic blood pressure under 90 or extreme heart rates like bradycardia under 40 beats per minute or tachycardia over 150, the alarm bells should be ringing. Throw in agonal respirations, an oxygen saturation dropping below 90% despite therapy, or a Glasgow coma scale under 8, and you are looking at a patient who needs priority resuscitation. Like, immediately. Section 2. Shockable lethal cardiac rhythms, VFib and Pulseless VT. So, when the heart's electrical system goes completely haywire, it stops pumping blood effectively. That leads to collapse and loss of consciousness. But, and this is crucial, not all cardiac arrests are identical. Take ventricular fibrillation, or VFib. Looking at the chaotic electrical activity on a rhythm strip, you'd see the heart isn't squeezing at all. The ventricles are basically just quivering. Because there's no organized contraction, there is absolutely zero effective cardiac output. Blood circulation drops to zero instantly. This is a primary cause of sudden cardiac arrest and requires immediate action. Now, in contrast, we have pulseless ventricular tachycardia, or VTAC. Unlike that chaotic quivering of VFib, VTAC looks like rapid, organized ventricular firing. The problem? Well, the heart is beating so furiously fast that it just doesn't have time to fill with blood between beats. The result is exactly the same: no palpable pulse and zero effective circulation. For both VFib and pulseless VTAC, the treatment protocol is immediate, high-energy, unsynchronized defibrillation, the shock, paired with high-quality CPR and ACLS pharmacotherapy. We're talking medications like epinephrine and amiodarone. Section 3. The flatline. True asystole. But what happens when there's no electrical activity at all? This is asystole. Look at that chilling flatline. This is the complete and total absence of myocardial electrical and mechanical activity. There's no heartbeat, and there is no circulation. It is literally the ultimate system failure of the heart.
So the absolutely critical point is this quote right here: defibrillation is completely ineffective in true asystole. You know, Hollywood gets this wrong literally all the time. You cannot shock a flatline because there's no errant electrical activity to reset. If a patient is in true asystole, survival depends entirely on continuous, high-quality CPR to manually circulate blood, along with administering epinephrine.
Section 4. Aortic dissection disasters, the internal tear. Okay, let's transition from the heart's electrical failures over to the structural plumbing catastrophes of the vascular system. Look closely at this anatomical model of an aortic dissection. What you're seeing here is a literal tear in the inner layer of the aorta. As high-pressure blood surges through that tear, it violently forces its way between the layers of the aortic wall, splitting them apart. This is often characterized by a sudden, incredibly sharp, tearing pain in the chest or back. Now, the location of that tear dictates both the severity and the treatment, which is absolutely crucial for your clinical understanding. Type A dissections involve the ascending aorta right near the heart. This is an absolute, immediate surgical emergency. If it's a type B dissection involving the descending aorta further down, it's typically managed medically with very aggressive blood pressure control unless serious complications pop up.
Section 5, Ruptured Aortic Aneurysms Explained, the burst.
All right, let's look at a totally different kind of vascular catastrophe. This isn't a tear, it's a burst, a ruptured aortic aneurysm. An aneurysm is a pre-existing localized bulging of a weakened aortic wall. Over time, usually due to things like age, smoking, or hypertension, this balloon-like bulge gets weaker and weaker until, bam, it bursts. Whether it's an abdominal aortic aneurysm, known as a AAA in the belly, or a thoracic aortic aneurysm in the chest, a rupture results in massive internal bleeding, rapid exsanguination, and profound hemorrhagic shock.
For anyone documenting or decoding a chart, distinguishing these two disasters is your gold standard. Notice the onset here. A dissection usually presents with sudden, tearing chest or back pain. But a ruptured aneurysm? That presents with sudden, severe abdominal or flank pain accompanied by deep shock. And check out the risk factors. Dissections lean toward hypertension and connective tissue disorders, while aneurysms lean heavily toward older males with a history of smoking. Both require emergency imaging like CT scans or ultrasounds to confirm, but their underlying pathology, a tear versus a burst, is completely distinct. Section 6, ICD coding for cardiac crises, translating trauma to code. So how exactly do we translate this intense physical trauma into administrative data? Let's review the core ICD-10-CM coding principles. First, the principal diagnosis must be the primary acute life-threatening condition, the main reason for the encounter. Unstable vitals, like those severe arrhythmias we just discussed, are secondary diagnoses. A major rule to remember, code cardiac arrest, the I-46 category, as secondary to the underlying acute trigger, like a myocardial infarction or severe trauma, unless the underlying cause is totally unknown. Oh, and always use combination codes when they're available. Specificity is absolutely vital here. You have to rely on the provider's exact documentation. You literally cannot assume. You must differentiate a non-traumatic aortic dissection coded in the I-71.0 series and broken down by anatomical site from a thoracic or abdominal aneurysm rupture, which uses entirely different codes like I-71.1 or I-71.3. Knowing the difference between a tear and a burst ensures the patient's record accurately reflects the clinical care they actually received. Let's bring all of this together with a clinical case decoder timeline. Let's say, at minute 0, a 66-year-old male collapses with sudden, tearing mid-scapular back pain. By minute 5 in the ER, he has profound hypotension and slips into a brief episode of Pulseless VT. He's immediately given high-energy unsynchronized shock, defibrillated, and stabilized. Fast forward to minute 30, and an emergent CT angiography reveals a Stanford type A dissection. So for our coders out there, how do we sequence this? Well, based on our rules, you sequence the type A dissection as the primary diagnosis because it's the root driver of the crisis. The Pulseless VT, which caused the cardiac arrest, is coded as the secondary diagnosis. Which leaves us with this final thought for you to chew on. The rule is usually to sequence acute conditions before chronic ones, right? But what if a chronic condition is the direct proven cause of an acute crisis? Does the acute or chronic code get sequenced first? It's a tricky exception that really challenges your coding instincts, and it's exactly the kind of nuance we'll be tackling in our next explainer. Keep learning, keep focusing, and I'll see you next time.